नमस्कार दोस्तों, good evening, Sat Shri Akal, Salam. Today we are here with another episode of Dr. Seema Pandey's talk show, The Knowledge Shots. Today I have a very interesting person who does not only represent the generation Z, but he is also a very big influencer, and he is going to give us a totally different view. Till now you have been just listening to all of us reproductive medicine specialist clinicians. Today I am going to introduce you to a doctor who treats the embryos, in whose hand our eggs and sperms are going, and they make us what we are today. So welcome Dr. Pratik Makwana on board. And before we go forward, I would like Dr. Pratik to introduce himself to our viewers.
Thank you, ma'am, for the very kind introduction. I'm a consultant embryologist, and on the side, I also try and increase some awareness related to fertility and sexual health, which I think at this moment is very important. And I've been involved with a few projects. I've worked with ESHRE in the past, and now I'm trying to be more active with our Indian societies because I think that's where the real work is happening right now. I mean, we have such great patient data. Only if we start using it properly, I think we can overtake any society right now. So that's just a little
Very
brief
true.
about me.
So Pratik is being very modest. He can like take masses and influence them, and three cheers to him and his work, whatever he's doing. And that's the way our, if this generation is going like that, so it's, there's no doubt that whatever evidences, as Pratik said, we have lot of data, and can become top of the world in any field. So here I welcome my co-moderator and our V4, Dr. Anuradha Khar from Bangalore, Dr. Arshi Iqbal from Kota, and Dr. Raj Lakshmi Walawalkar from Thana, Mumbai. So, Pratik, to begin with, how do you look at the infertility, and especially we are talking about assisted reproductive technique, infertility where treatment is IVF? What is your view? What are those things which make some eggs very great, or embryo it culminates into, that has the property of giving a good pregnancy?
Ma'am, I think, if we just look at the very start, very beginning, it's the few most cliched things that we keep mentioning every day is that you can only control your lifestyle. So if you have controlled those very important factors, and no matter, see, going for IVF is not really a bad thing now. Like people used to have very big taboos around it when it all started, but now it's a pretty normal thing. So if you just control your lifestyle factors, even age being a very important factor, but we know there has been a shift, and now people are going for pregnancies at a much higher age than before. So let's keep that aside. But if we just control the lifestyle, the quality of the eggs and sperms that we get from the get go are relatively much better compared to if now that we have so many stressors with smoking, drinking, so just not eating right, not working out. If we only control those factors, pathologies aside, I think we get really good quality of embryos, from the eggs and the sperms. So I think that matters. Other than that, seeking treatment early rather than waiting for a long time to go to the center, because I mean we still get cases where people have been waiting for 10 years, 8 years, 7 years, and then
That's
they are
right.
coming. So I think that is also, if you see that there's a problem, now you have so many options, just go and seek treatment. I think those are the first few factors that I would look at, which can give us very good quality eggs and sperms.
So that is
I
very
think
important. And if I can share my viewers in, so younger generation आपके लिए स्पेशली ये लागू होता है, बहुत सारे जो सीनियर्स लोग हैं उनको शायद ये चीज़ उतनी समझ ना आए, बट आपके लिए बहुत इम्पोर्टेंट है। डॉक्टर प्रतीक का कहना है कि चाहे वो आईवीएफ ट्रीटमेंट हो या नॉर्मल इनफर्टिलिटी का ट्रीटमेंट हो, आपकी लाइफस्टाइल बहुत ज़्यादा मैटर करती है। और इस ज़माने में जब हमारी ज़िंदगी 24/7 एक जैसी चल रही है, हर चीज़ हर वक्त अवेलेबल है, यहाँ भी आपके रूटीन, डिसिप्लिन एंड आपकी हैबिट्स ही मैटर करती हैं, तो उन पे आपको ध्यान रखना बहुत ज़रूरी है। साथ में समय से इलाज कराना, समय से, अगर आईवीएफ ही आपकी चॉइस है, आपके लिए बेस्ट ट्रीटमेंट ऑप्शन है, तो वो अगर आप समय से डॉक्टर के पास जाते हैं, तो एज रिलेटेड जो डिटेरियोरेशन आपकी oocyte और स्पर्म की क्वालिटी में है, वो कम होगा, जिससे आपको अच्छी सक्सेस मिलने के चांसेस बढ़ जाएंगे। एम आई राइट?
So,
या
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 सीमा,
Continue to
मुझे
this,
यहाँ पर, सॉरी,
what Seema is talking और अपने दर्शकों को बता रही, तो प्रतीक, now the question comes for the newer younger boys who are, because as we are seeing, sperm quality and the parameters are going at a very higher pace to a lower level. So what is seen in today's parameter, आपका क्या उन लड़कों के लिए या उन younger generation के लिए मैसेज है कि what changes you are seeing in the sperm parameters which were not there 10 years back, what is growing at a faster pace, and जो आजकल एक नया कंसर्न निकला है, gyms and these supplements, उसके बारे में मुझे लगता है कि आपको एक टेक होम मैसेज इनको कुछ बताना चाहिए, क्योंकि मोस्ट ऑफ द पीपल आर बिजी विद दीज सप्लीमेंट्स, सब प्रोटीन सप्लीमेंट्स। सो सीमा
so
के
I'll tell
उसको
you what.
क्वेश्चन करते हुए,
You know, two things have happened. जब ये बात आती है, there are two things you have to look at. Fertility has been on a constant decline for the past 30 years. The graph is very steep now. But एक रीजन ये है that the testing has increased a lot. पहले टेस्टिंग कम होती थी तो केसेस भी कम आते थे. अब टेस्टिंग बढ़ गई है तो केसेस भी बढ़ गए हैं. सेकंड, एनवायरमेंटल फैक्टर्स, एनवायरमेंटल स्ट्रेसर्स बहुत हैं अभी. उसके ऊपर से नाउ विद टाइम जहाँ पे एवरीबडी वांट्स टू हैव अ लाइफस्टाइल विद दे वर्क हार्ड, प्ले हार्ड, तो वहाँ पे इनका नो द वर्क लाइफस्टाइल, देयर इज नो एक्टिविटी. They want to do physical activity. They'll sit on a bench, sit on a computer all day for multiple hours at stretch. Or after they're done with all that stress, they will go out, पूरी रात पार्टी करेंगे, they'll drink, drug abuse, smoking. So that is definitely going to affect your sperm quality. वो सबसे थी. Whenever अपन health की बात करते हैं, we see so many videos on YouTube. Everybody is talking about how to stay fit. Nobody is looking at fertility. वो सब तभी याद आएगा when they are trying to get pregnant. Then they will realize कि, oh shit, our fertility has gone down. And तब तक they will forget all the reasons कि इतने सालों से हमने क्या किया है. They won't know. Second, when it comes to gyms, see, supplements, taking supplements, the idea behind that is कि what you cannot consume in your normal diet, you supplement through various supplements that you have. But people have forgotten that. Now they want quick results, so they'll go for steroid abuse, not realizing that initially, while you're getting the boost, when your cycle of steroid it, it's completely off, the size of your testicles will shrink. Sperm production will stop. Your body is so used to taking testosterone from outside sources that it will not produce its own testosterone. So your levels have dropped, your testicles have shrunk, there's no sperm production happening. And then by that time, coming to that point after 3 6 months of steroid abuse, you have done so much damage that sometimes it's now irreversible. If you're lucky, you might be able to reverse the damage by stopping the use, give yourself 3 months, get the factory to start again. But तब तक people don't realize this. उनको चाहिए बस हमको body दिखनी अच्छी चाहिए. What happens later, we'll see.
Uh, I have a point, Pratik, that as you said, they take steroids. See, whenever we think of testosterone, I think people who are not aware about its side effects, they always link it to the the male thing, it's a
Yeah.
male hormone, it's a hormone of strength, and they mistake it for virility, will become virile by taking testosterone. This is a very big misconception which people have, and
Yeah.
today on this forum, you have cleared it so nicely that it may cause permanent damage. So I agree to every point you have said.
Also, if
I
I
have
can,
a sorry. Pratik,
please go
you
ahead,
go
ma'am.
ahead.
Please
I'll
go
talk
ahead.
to you.
Yeah, Pratik.
Yeah. Okay. So testosterone has always been linked to very macho displays of strength, even in Bollywood and all. Recently, there was one particular incident. I was going through some very nice research article, and it said a happier man usually has higher testosterone. So the calmer the man, the happier the man, the better the testosterone, rather than we see the overcompensation with aggression.
Good, good
Uh,
one.
I just want to add a little bit of more to this testosterone intake. So, initially young age में करते हैं, as Pratik very rightly pointed out, the testicular size sinks, and the natural hormone production is going to get suppressed over the long run. What these men don't understand is that in the while trying to look more virile in the long run, because the testosterone goes down, their compensatory female hormones go up and they start developing breasts and everything. The benefit that testosterone gives is only for short term. Like a few years they might show more muscles, they might show a better body, but afterwards, when because they cannot keep taking supplements for lifelong, kahin na kahin to wo ruk jata hai, and fertility will get damaged. Fat production increases, they'll deposit more fat, they'll very typically develop male breasts, and then they go exactly opposite in their swing. From looking fantastic, they might end up looking really bad. So this is something that all the young boys need to understand. Yeah. So
Absolutely right,
So
ma'am. Absolutely.
Pratik,
here
sorry.
I
Um, I have a question
yeah.
for Pratik. He talked about poor egg quality. So for our viewers, can you define from a embryologist point of view what do you call poor?
So right now, the only standard that we have to grade an oocyte is the morphology criteria that are available to us. They are very superficial and there's not much development in that. But because we look at the morphology and that's how we go for it. So we have a standard egg size about 118 to 120 micrometers. We are used to seeing a nice, outer membrane zona as we call it, and the particular oocyte characteristics. Now, for an embryological standpoint, we do grade oocytes and we do follow them to see how they develop into embryos by doing microdroplet cultures. That's something that we do. But the more we look at it, it's also the role of the sperm is very important when it comes to the development of embryo. Yes, there is when the egg has the tendency to correct a lot of defects in the sperm. But even if there's a poor egg quality and there's a very decently good sperm, you can get a very good embryo. But if the sperm is completely gone, if you're picking up, if you're, the already choice of sperms is very bad, and to add to that, you either have a grade two oocyte, because in oocytes we grade with one and nil. So if you have a grade nil oocyte from varying degrees, and if you have a good sperm, there's still some chance. But if both the factors are off, then it's very difficult to get. Even if you get a very good looking blastocyst, very highly unlikely that you'll get an implantation.
So
So I have
that
one
was my
question.
question. Just this way. That was my question, because most of the time, Pratik, when you make a grade 5A, 6A, or 4A blastocyst, and you go for transfer in fairly good endometrium with triple line, more than 8 centimeter, grade 4 blood zone, and it does not implant, and then patient comes back and asks, madam, you said that my blastocyst is there and that is of good quality, and endometrium was very good, then what went wrong? So here, whatever we have read in literature, that if a blastocyst is not implanting majority of time, if it is a fault of blastocyst, then it comes from paternal side. How true it is, and how do you define it?
That is extremely true. So, that's why now we have so many tests to add on. Guaranteed, they haven't showed any evidence to its use or increasing the implantation rate or increasing the live birth rate. But what we have to consider is the time to conception rate. That has reduced when we use these add-ons in specialized cases only. But still, it's very important because that way you can at least pick sperms which have a higher DNA integrity. And for the oocytes, the most you can do is you can track how the embryo becomes from the oocyte. So a lot of people refer to Istanbul consensus for grading. I would personally say that the Esabir consensus, the Spanish consensus, is much better because it has tracked all the all the characteristics. And it's very nicely mentioned in that if you have a grade 2 embryo on day 3, and if you get a very beautiful blastocyst, you can never grade it as grade 1 because it has the footprint of that blastocyst has come from a poorly grade, a poor grade embryo. So of course it will affect your implantation, be it coming from the sperm side or just the whole embryonic genome is activated and you have a poor quality embryo.
Okay, Pratik, there is a big, I mean, last few years we are seeing about time lapse technology, to track, as we are discussing now, embryo quality. So it has been now and then always said that, time lapse may the early cleavage embryos will always be good quality. Can you throw a little light on this? Is that if time lapse is the answer for our selection of embryo for transfer, why everyone doesn't have a time lapse technology? Even if people can afford, everyone is not coming forward to putting that technology in their center. Can you throw light on this, please?
Definitely. We have had a time lapse for the past decade, and now, of course, the company has come and said, okay, the software support is gone. Now you need to buy a new one because 10 years are done. But what I would say is that time lapse still remains a very experimental technique. You don't require it in your lab. You can just see your embryos every day, as manually as we do with benchtop incubators or box incubators. But the idea behind time lapse is that if you just remove the morphological uh, parameters, you can now also see the kinetics of the growth. That's why the morphokinetic analysis, as it's now termed, instead of the morphometry analysis that we do with our normal embryos. But just paying a huge amount only to get that little benefit for research purposes, it makes a lot of sense. For patient purposes, not so much because the technology is unvalidated. You have incurred high initial cost, and to recover those costs, it's again now an uphill battle. Plus, all the dishes that you get, all the disposables that you get, specialized dishes you need for that incubator. Plus, even the media will, if you're doing a sequential culture with time lapse, you'll have to switch to a one step media. And people usually go for the higher end medias because they're specifically made for time lapse. I just don't want to take any names here. But now, with that in mind, it does not really seem like a worthy investment. And now, with artificial intelligence on its way, the only incubator that will be using it to the extent is a time lapse incubator.
Mhm.
And now, with artificial intelligence, you'll also have to pay that yearly price of using that software, which is already very high. And all the data they have is based on European demographics. And we have seen it in studies in fertility, sterility, even some papers in ESHRE, that ethnics matter a lot when it comes to your embryo quality. They have different studies for Hispanics, Caucasians, and and especially white Europeans. So why are we using those studies and the data from that in the AI softwares and using it on our patients when even they say that the ethnics matter a lot? So right now, I mean, you can get it if you
So,
want to go into research, but other than that, it's
so
not necessarily.
So it is not a mandatory, it's not mandatory for an IVF lab to have this time lapse. I mean,
No,
What
not
is
by
your
any measure.
take? Like, did it improve your pregnancy rates? We come to the crux. Did it improve your pregnancy rates
No,
than
ma'am, we haven't seen. Yeah, we have seen. I mean, it helped us to grade the embryos better. It helps us to pick the embryos better. But over the last 10 years, I think using a bench top, sometimes even using a box incubator if the cultures are full in both the other incubators, I don't think we have seen any significant or any remarkable change using a time lapse.
Pratik, I just wanted to overemphasize this fact as you mentioned the ethnicity. As of our Indian subcontinent population, it is already established that our ovarian reserve l- lasts lesser period of time than like Caucasian and other population. Apart from that, it is also said that our fertility rate and fecundity rate is lower than the other populations, apart from Africans, if you forget. So, for our viewers, I just wanted this thing to be emphasized that as an as a race we are born like that, that our fecundity and fertility potential or reproductive span is lesser than rest of the world, and we have to use it wisely and timely so that we can enjoy the full potential of ours in terms of having our progenies.
That's true. Also, there was a very recent podcast that I was seeing with a very famous doctor, as you know, he was a guest, a very famous Indian doctor. Uh, Now, what he had to say was that initially, say before 1950, the life expectancy in Indians was about 35, and right now it has increased to 71. So, as we are developing, as the nation is developing to a more developed, now we fall into that category. uh, the life expectancy has increased, and also because of that, the number of diseases that we now encounter has also increased. Because earlier, all that we were getting were diseases up to the age 35, which were affecting, and we had very early pregnancies in that, up till 1950, before independence. They were very early pregnancies. But now that the life expectancy has increased, new, especially the diseases that we see in old age, has now started to come up. We see a lot more cancers. Prostate cancer has become so common now. Earlier it wasn't. Now it's the second most common cancer, especially in the metro regions. So now that is now that we have started now with late pregnancies, now we started to encounter a lot of new problems, which has also contributed to the decline that we are now seeing in fertility.
Apart
I
from
think also, the pollution, the pesticides which are being used, the overproduction of food, and the artificial environment storage in which chemicals are used to even mature the fruits, or that, I think everything takes a toll, on these things, and we consume that, and probably that could be also because low ovarian reserve is multifactorial. There can't be one single reason which we can point out. So probably this also could be a reason for this.
as a country we are just growing also, and for a talk of mine day before yesterday I was just going through infertility in this era, and forecast for 2100 was that 1.3% population by 2100 throughout the world is going to be above 65, and we are going to have lesser number of youngsters, especially 20 years and younger. And that is also going as an in Indian democracy we have got matured, we were young, we had the highest potential of youngsters till now. Now we are entering into middle age, and that also, along with our work habits and our um, blindly following Western culture, especially Western style of diet, not looking at our own local, our own regional variation and factors which are affecting us, that is also taking its toll overall on making these diseases more prevalent. For example, we have become the diabetes capital, PCOS capital, definitely, because we are not
Okay.
looking into it, we are not producing the data. And regarding sperm quality and all those factors, these are basically kind of demographical changes which we are not realizing right now. And people like you, me, us, we have to make our society aware about all these changes and how to go about it. And that's, I'm really glad the way you have been like speaking about all these things. And I'm very sure that people who are watching, a lot of doctors are there, and they are going to get. So here I would just like to conclude whatever Pratik has said till now, that technology is there to complement your clinical acumen and your laboratory excellence. It is not going to replace it. For example, that this thing we were talking about just now, embryo, oh my god, please help me
Yeah,
find the
artificial
word for
intelligence
this.
with time lapse.
Artificial
No, no,
Embryoscope,
intelligence, but
embryoscope,
Embryoscope.
time lapse,
embryoscope,
time lapse
Embryos.
embryoscope,
technology.
yeah, time lapse. For example, time lapse, it is not going to improve your pregnancy, it is going to help you research how our embryo is going growing and how and where to intervene. And it can just help you select the best, but it cannot replace the lifestyle you have ruined earlier age, and you have come very late for your pregnancy. For last 10, 12 days, Pratik, since we started this knowledge short, we have been talking about age and lifestyle factors. So apart from that, when we move further ahead and we are talking about the pregnancy, and like from your point of view, how much a clinician is participating, like contribute in making a good embryo, and how much it is the lab work, on lighter note.
I think it has to go hand in hand because the stimulations are the most important part. If there has been a little up and down in the stimulations, we'll start seeing eggs with with SER discs also if the stimulation is too strong. So it depends, and for that a decision has to be made that every patient now there's no set protocol for like every stimulation is very individualized for the patient. So I think the clinician plays a very big role over there. And from that, what the eggs do we like, whatever eggs we get, and especially also for the side for the men and for the sperms that we get, it's very important that it has to come hand in hand. Otherwise, if we don't have good eggs, we cannot make good embryos. And the leaving the doctor side aside, it's very important for the patient to also, the patient compliance plays a very important role over here, which is always, never looked at, basically.
Yeah,
Pratik,
I
I
mean,
have one
uh,
question, small question.
uh,
That you have the eggs now. You are doing ICSI. How do you select the sperm? Do you have that IMSI thing, or do you do a visual through the microscope? What we do, stereo microscope. How do you select your sorry, inverted microscope? How do you select your sperm? The
We
best.
have MC, but I don't use it anymore. I am very vocally against MC. It is a very obsolete technique now. Plus, I don't want to waste that much time in selecting a sperm via MC when the morphology being such a subjective criteria. I mean, we have sperm counts which don't include morphology as a criteria. I mean, if you go for total motile sperm count, there is no
Yeah.
morphology criteria is not included in the reading itself. And if you want to still pick a sperm which has a higher DNA integrity, instead of wasting time in MC, you can either do a microfluidic, which is much cheaper, much quicker, and you can completely skip the centrifugation. Plus, you can always do a pixie. Even that is now available. I mean, widely used. That can completely blow MC out of the water. So MC, I don't prefer using on a regular basis unless indicated for a patient with repeated IVF failures or recurrent pregnancy losses. I would always go for just picking the sperms under the on the inverted microscope, at 100x, and that's about it. That's the most. And I would give a lot of time to pick the sperms. I will keep the eggs inside the incubator. I will take my sweet time picking all the sperms that I want, place them in a different drop, and then get the eggs and just go with the sperms that I've already picked.
So basically, motility and how they look like,
Yeah, I mean, if you're picking up if you're not using any other method, you kind of have to look at how they look on the outside. The morphology then plays an important role because there's no other criteria available to us. For the past 40 years, semen analysis hasn't improved at all. It's the same thing that we have been doing, and it's going on probably, until there's a major change.
Yeah, though we have had CASA coming in, I mean, computer assisted sperm analysis, but again, that's not available in every center.
Yeah, and
And
that's not very reliable also at this
yes,
moment.
That's
yes.
what my
And
Yeah,
next
again,
question was.
uh,
How
no,
reliable?
no, no. I have
Raj,
a comment there. I have a comment there. So, Seema very rightly asked him, clinician and embryologist, who contributes how much. He very nicely put in also the patient in the equation. But when I counsel my patients, I also tell them that if you read Richard Dawkins, there is something called as God particle 2. That was my comment there. But
Yeah.
having talked about the clinician aspect of giving you good quality gametes, we know that in certain patients, despite the best efforts at our end, preparing the patients and the best simulations, the best individualization we can do, there are patients who still end up giving you a follicular and egg maturation discordance, and you will end up getting discordant eggs in your petri dish. Pratik, what do you do then? IVM came in with a huge sweep, and then people said, "Ab IVM nahi karna." So, what do you do?
In those cases, see, we have tried doing inseminations at day one. See, you can leave the if you get a cohort where 50% of them are immature and 50% are the usable eggs, no matter the quality, you have to inject them. Unless it's a giant oocyte or there are two distinct, separate, you can see. Otherwise, you have to inject that oocyte. There's no other option left. For the remaining GVs, you can still, culture them to day one. Hopefully, they mature. But in my experience, I have never seen or read a recorded implantation from a day one oocyte, from a day one insemination. So there's
Pratik,
not much options there.
yeah, Pratik, about how about you get M1s and M2s? What do you do with those M1s? That's
With
my question.
M1s, we can still wait a little because see, getting M1s is very very rare because the time that we take after the ovum pickup to the ICSI is that 3.5 4 hours is for the M1s to mature. If you're still getting M1, wait for a couple more hours and then you inject whatever M2s you got. The rest of the M1s you inject after a couple more hours.
So, what is your stand for ICSI for all?
I think after COVID, I have shifted to ICSI for all because we shifted to ICSI for all and then we haven't gone back yet. But before that, we would always do a split, a 70-30 or a 60-40 split with 70 or 60 going for ICSI and the remaining for conventional IVF. But
But
right now, I think ICSI for all.
what has COVID done? I mean, why did you change the strategy after
There were
COVID?
so
Is there
many
any
uncertain,
relation
yeah.
of COVID? Yeah.
Yeah, because there were so many uncertainties. Plus, then the studies came out that sperms and eggs they both have receptors for the virus. It's like I don't want to take any chance. I don't want to put the egg with so many sperms. I would just pick one and do because that's the other option that we have left. There's nothing we can do. So
Pratik,
So,
what is
yes,
this
Pratik,
black
we are
oocyte?
answerable also. We
yeah,
are
we are
answerable.
answerable.
Like you have done so much, and then you leave it for IVF, and if they don't fertilize, the patient is definitely going to ask us, Why didn't you do ICSI? Right? That question always is
That
there.
question will always come, yeah.
Yeah.
Also,
So
I mean, even with all the technologies that we have, even with, say, aneuploidy screening, structural rearrangement, merging disorders, there was a very famous case in Australia. A fertility center was using non-invasive. Now that NIPGT is very as becoming a thing, they used it a couple of years back on their patient, and they gave a report of aneuploidy. And the patient, and when the baby was born, there was of course aneuploidy. The patient I mean, even with the chance that, this much percentage chance on the report, because NIPGT was very new at that time, the patient sued the IVF center for 3 million Australian dollars and they won. So we are answerable. And if people do take action on that, even though they are well aware of the risk. So now we are, I think, much more, informed, and we take consent on everything just to avoid that particular incident happening, in especially with us in India.
So, Pratik, here my question is, what is this black oocyte all the embryologists keep telling us? And first thing, which I could never understand. And second thing, for viewers' point of view, would you like to tell certain situations where IVF is preferable, looking at natural versus artificial selection, where you would like to certainly do IVF? And what if, and third thing, as you were talking about non-invasive PGs, what is your choice? And for viewers' sake, what is the difference between two, invasive and non-invasive? I have put so many questions for you.
Okay, so a black oocyte is usually, there are different meanings of black oocyte. The most common one is the atretic oocyte, which is now post mature. We will now think about immaturity, but we have got an oocyte which is now post mature, which has grown so quickly. Sometimes even when we do a ICSI, say a little early, or the pickup has happened a little late. So the time to ICSI, is 2.5 to 3 hours. In that particular time, uh, sometimes you get embryos which are eggs which are growing very fast, and so when you inject them, you might get a blastocyst at day 4, you know or you get a very early cleaving embryos. Now in that particular case, especially the eggs which are responsible for that, if you wait for a certain time, they will immature very quickly. By the time they're out, they've cultured, you go to strip them of the cells, and you will see that they've already become atretic. So the multiple reasons for, we still don't have a proper reason of why this happens, but yeah, atretic oocytes are what we call black oocytes, and we can see them right from the screening part. Because the cumulus will be very tightly packed and will be complete black. That's why the very common term of black oocytes come. The second question, I think, was, I've forgotten the second question that you had asked.
Where you prefer doing IVF over ICSI? Is there
Okay.
any situation?
Yeah, by default, we should be doing IVF. So that is the first preference. But now we have moved to ICSI for all, I think, But yeah, especially if you have no male factor, I think IVF is because even if you have one egg, there's a very good study. Even if you have one egg, and I've seen that you do IVF, you do ICSI, you get the same result. You know, there's not much difference. It was I think it was in fertility sterility in 2017. If you still look for what to do with single oocyte, that's the first study that will pop up. So if I think ICSI is only recommended in male factors, but now no matter what people claim, I think all over the world people are doing ICSI for all,
It's just
because
like
you get,
cesarean
yeah,
versus normal delivery. Why cesarean rates are increasing? And that was the question I was asked. The first thing is that person coming to us, parents, and asking, why didn't you do it earlier? Same with ICSI, I think. Why didn't you go for ICSI? If you
yeah,
do IVF, and it takes you to fertilization failure.
yeah.
And third
Also, I
question
think
was,
it
yeah.
gives a peace of mind to us because we know exactly when we have inseminated, rather than pondering over which hour the sperm would have inseminated the egg with conventional IVF. So I think that peace of mind has been one of the most important you know reason for people shifting to ICSI for all. And
Pratik,
yeah.
sorry, I want to take you back to the egg again. A lot of times patients do come with previous cycle reports where the eggs, the comment is that the egg had vacuolations or pitting. Can you explain this in simple words for our non-medical viewers today?
So basically, vacuoles in cell is usually to provide some sort of nutrition by default. But eggs should not be having vacuoles after a certain, after they have gone through their oogenesis. So when we get the egg, we are not supposed to have vacuoles in it. And especially smaller vacuoles, we can still adjust and go for ICSIs. But I've never injected an egg with a vacuole over 16 micrometers, because I have tried and I have looked for some papers, but I have never seen a paper supporting any sort of fertilization or development past day 3 in eggs which have had vacuoles that big. I think 14 to 16 micrometers is the cutoff. Until then, you can still deal with the vacuoles. You not do much, they will stay, but even when the embryo is growing, you can see that effect of vacuoles on your embryos, because they do take up a lot of space. But other than that, you know you're good to go with the vacuoles as long as the size and the number of vacuoles are in check.
The part two was pitting.
With pitting, first it's very important to differentiate a vacuole and a pitting, because people usually get confused, you know. And I think a very common way to see is a concave and a convex structure. When you look at a vacuole, it will be a concave structure. There would be like an appearance with this a shadow behind the vacuole that you're seeing. With pitting, it will give you a more moon crater appearance. But even with that, it has not really affected fertilization and implantation. Implantation, I cannot say, because you have to track the embryo, and I don't think we have tracked them in pitting. Especially, we haven't done it at our center, so I cannot say much. But you will get blastocysts, you will get embryos. Now, it has been linked, to poor implantations, but I haven't seen much of a difference.
Pratik,
Dr.
only one
Pradeep,
thing left, invasive versus non invasive for our viewers as well as our doctors. It is comparatively new thing. Before we call for our shots, because the discussion is going so interesting that we have just passed 42 minutes and it was a 30-minute show. So, Pratik, just tell about that. And Arshi's quiet today.
No, I have asked a few questions, but the thing is, everybody has to get their partner to ask.
Pratik, I have to ask one question, but you answer this first.
All right.
I'll ask.
So with invasive and non-invasive, the difference is what we have in every medical field. With now we are trying to move towards non-invasive procedures. So with invasive, I think we are all aware that we take the cells out of the trophectoderm, because that is a representation of the ICM. With non-invasive, we go for the cell-free DNA which has been excreted out into the culture media around the blastocyst. The idea is that DNA would, in some form, when amplified, would give you the picture as is, because the genetic material in a blastocyst is pretty much the same from trophectoderm to ICM, and ICM is the one which you want, which you cannot touch. So instead of poking around trophectoderm, we'll just go for the DNA which is now excreted. Now, now that non-invasive PGT has shown very good concordance rates, so right now it makes sense to try that technique. But for the past 10 years, all PGT for aneuploidy has changed its name from 1.0, 2.0 to 3.0. None of the policies have been addressed. Instead, every time they come up with a new version, they will say the same things in different word, not address any of the backlash that they've gotten over the years. And now they're coming with PGT 4.0, and now they're coming with PGT-P also for monogenics, and now they have polygenic. But none of the things have been addressed. Monogenic still makes sense because you know exactly what you're looking for. But I think aneuploidy screening, be it NIPGT or PGT, is, I mean, it could be given as an add-on just because patients now are already Google informed. They would come and ask for PGT. You can give them, I mean, you can tell them the benefit of the technique and the cons of the technique, but I don't think PGT for aneuploidy, be it invasive or non-invasive, holds a lot of value right now.
So my question right now over here is, uh, what is the size at which you will prefer early trigger or late trigger? Something like when that X touch 16, you see the egg quality. What
Yeah.
clinician gives you. So you prefer 16 size, or you prefer 18 or 20 trigger? What is the take home for the clinician? Where the
I
exam?
don't think I would be the right person to answer that. I think you would be able to explain it much better.
No, we
Because when
usually
it
do,
comes to,
but the
yeah,
quality of egg, which is better, whether it is on 18, giving trigger at
there
18
is
or at
no,
20.
yeah, there is no correlation with that, because even if you track the follicular fluid volume that you get with every tube and the number of eggs that you get towards the end, the ideal is that it's supposed to have around 3 to 5 ml of follicular fluid that you're supposed to get for one mature egg. But you can even get good quality of eggs with 1 ml of follicular fluid per egg, or you can get immature eggs with 7 or 8 ml of oil. So that correlation is not very strong. You can still get good embryos at 16, 18, and 20 micrometer size. So it doesn't really affect a lot.
Dr. Pratik, last question before we wind up. Um, we have stimulated a patient, egg pickup done, you've done the ICSI. Next day, failed fertilization.
Yeah.
Now, patient, we are counseling. Again, patient wants to try once more because, IVF, we know that every cycle is different. They say, no, doctor, we'll take one more chance. Now, next time I've done the egg pick, I've given eggs to you. What else you would do? Because she has a history of failed fertilization.
So by the time we start the next cycle, when the first time the failed fertilization happens, the instant response is to see if any pickups on the same day also had the same, also had
Yes.
failed fertilization. If they didn't, then we can isolate the issue to a very patient specific issue. But if it affected the other cycles also, then it could be an issue with the culture system, the culture medias, the temperature in your lab, the skill of the embryologist. A lot of things will then come into question. But if it's that only one patient, then we will have to go and track every step of that patient, you know, and maybe try to find what could have affected that also at the sperm. Because once you have singled out the issue, now the idea is to go and target that issue and find that issue. So the next time the patient comes, you don't have to, sort of go with the same fear in mind. And after a failed fertilization, I think you have to look at certain treatment options. Like you just definitely go for a DFI for the semen sample, and definitely look at the stimulation protocols also, because that can also affect the quality of eggs.
So,
Pratik,
from the lab perspective, we have changed the protocol, we have done everything. From the lab perspective, you'll still do the ICSI, you will go in the same manner, or will you change something in your lab?
No,
Like,
we would definitely see, because in that particular case, before going for ICSI, what you can treat more is the sperm. You can go for, you can go to pick the best sperms. You can go for Pixie, you can go for micro. You can first do a DFI, and you can try and reduce the chances of getting a. If you get a high DFI in that case, then you can go for various options available to try and pick the best sperm possible. Also, if so, now, you know especially now, if the patient has had multiple cycles and now they have seen failed fertilization, in that particular option you can also offer them sperm donors. That is one thing that you can offer. If multiple cycles have already been done, then there's no point going trying the same thing again and again and again. In that
is
particular
there
case, you
a,
can do a split. You can do a
sorry,
split.
will you do a split? That's what. Is there a
Yes.
Yeah,
role
yeah,
of
yeah.
IVF in the next cycle? Is what I wanted to
No, I
ask.
would do a split with
split
with
means
the
Because
donor
it's a
and
husband's,
self.
yeah,
natural
donor
selection
and
Donor and
process.
husband's.
self.
Yeah.
Yeah.
Pratik,
You'll
that
do a
brings the
split.
next question from my side, though it was supposed to be last. That what is your take on testicular sperm in these patients of DFI? How often do you do? And second part of question is, what is your preference, fresh versus freeze all, as most of us are doing in majority of our cycles, for a patient where we've got two or three oocytes which made one or two blastocysts?
Yeah.
Or day three
So
versus blast?
I think so. For the first question was related to sperm. I think I've missed out
Yeah,
on that.
yeah, testicular sperm.
Testicular
Testing.
sperms. Yeah. So I think,
In this scenario where you were talking right now,
yeah. So a
before
lot.
asking for donor.
Yeah. So because I said, that first you go for modalities to reduce the DFI. Right now, there are a lot of options available to reduce DFI from the ejaculated sample. You can have multiple ejaculations, after half an
Yes,
hour gap. That reduces the DFI. You can do PICSI. You can microfluidics brings the DFI to less than 1%. So even from a 25% DFI sample. So I think going around picking and prodding the testis, first we should, exhaust the external resources that we have. Only then we should go for
I
testicular sperm.
completely agree to that.
Yeah.
Multiple ejaculate is far better idea
But
than going invasive and doing testicular sperm. Yeah,
definitely, definitely. So I think once that is done and that has happened, then you can ask for a sperm donor, and even then, you still go for a split sample, and hopefully, it works out. The only caveat is that people forget is that you can only transfer one set of embryos. You cannot transfer two genetic material in the patient.
together.
Yeah,
That's
Yes.
true. The donor will obviously be separated,
yeah,
and
yeah,
you have to write, you have to label
yeah.
them
You
like,
have to make separate
yeah,
cultures. You have to
you have
have
to
everything
make
separate.
separate culture, separate dish, separate freezing in the,
Yeah,
straws have to be different, and labeling your IDs, everything will change then.
everything will change. Yes,
Yeah.
and I think as far as freeze all
I
and fresh.
Freeze
sorry.
all.
Yeah, as far as freeze all and fresh cycles go, I think for patients looking for a very less time to conception and very less embryos and eggs, sometimes we do go for fresh cycles. But if we want the patient to pool her embryos or pool her eggs, then we would go for a freeze all cycle. By default, I think right now freeze all takes the cake because there's so much convenience for the patient, you know, they can get the time for them to recover and then come back, rather than having the stress of a fresh cycle. But I don't think the rates have changed with any. I think you can still get as good rates as fresh as with freeze. So that still remains, that's a very debatable topic.
So
So
you
yeah,
are doing fresh transfer, right? You
Yeah,
are
we
doing.
do fresh transfers. We don't do freeze all, and we do majority freezing cycles, but not freeze all.
Okay.
okay.
Thank you, Pratik.
Okay.
So here, yeah, Raj is saying something. Yes.
I just want to ask him one last fun question. We've had a very serious discussion so far. So we'll end with a fun question before the shots. Pratik, in your experience, you said some embryos are very fast growing, they cleave very quickly, right? Have you ever come across an embryo, splitting completely because it was growing so fast? You ended up with one egg to start with, but ended up with two embryos at the end from that egg. Have
Yeah,
you
we
like seen
have
that
like
happen?
very rarely, I think once or twice, but there have been
Okay.
instances where I've seen eggs where the number of cells was amazing. I mean, instead of getting 8 cell embryo, we got like I think in multiples of three. I think 21 cell or some embryo that we got. And because it was in a benchtop incubator, I thought it could have come from a 3 PN stage, so I left that aside. I was like, I'm
Okay.
not going to use that.
Okay.
So you get very rare cases like that. Yeah.
So, Pratik, the here what we end this session by giving our three shots. So this is our custom to give the first chance to our expert. So you have to give three shots to the viewers out of this whole discussion.
Okay. 3 shots. Oh, very interesting. Very interesting concept. I think the one would be a very cliched shot. that do whatever with your life, stay away from the smokes. See, people are gonna drink. That you can regulate, but even one cigarette is enough to
Yeah.
to harm you. So stay away from the smokes. Second would be if you want to delay your pregnancies, now you have egg freezing available. Look into that. And the third probably would be I think the what we had discussed, a happier man usually has a higher testosterone. So I think focus on that rather than looking for other ways. Yeah.
Excellent shots. Yes, Anu.
So, looking good, handsome, and smart, and good body is good, but
TDH.
don't fall prey into whatever your gym instructors are giving you in that bottle or pills. Always question what is the ingredient in that, and don't get pushed into too much of exercise, because we get sudden cardiac deaths in the gym. We've had a lot of instances. So first take care of your health, and you have the right to question that what is there. Stay away from those steroid infused powders, or capsules or whatever. That's my first shot. Second is, even if a man is delaying to be a father, they can also freeze their sperms, and it is very easy and non-invasive, not like egg. So even the males should go get their semen analysis done out of choice, not when a doctor says, and get their sperms frozen. That's my second shot. Third is, as you said, clinician is very important with stimulation, but without lab, clinician is nothing. So it is a unison, I would say, between the clinician, the ultrasound, embryologist. They have to talk to each other. They have to. It's not, the lab cannot work independently and not give inputs to the clinician. And the clinician also, if there has been a problem somewhere, has to tell the embryologist when the egg pickup is done, so that embryologist is ready with extra things. So that's my three shots today.
So now I'm coming. So I'll start with your biological clock is going on and on. So age is the most important thing, and your lifestyle, proper lifestyle with no artificial supplements is a must. Second, good workup of the patient before starting any stimulation, and proper stimulation doses are a must for getting a good egg or a good embryo. Third, a good communication between your embryologist, between your lab and you is very important. Done.
Raj.
Okay, so almost everything is covered, but I'm going to give my three. The first one is you are what you eat. And yes, there are going to be multiple factors which are going to be governing the quality of the cells that you produce. But if you eat correct, if you take in antioxidants, avoid alcohol, smoking, you may not be able to make a dramatic difference in the quality of gametes that you give to the lab, but yes, you will be able to create a little change which might be enough to giving you a good quality embryo. That's the first thing. The second thing is specifically for poor responding patients. So we talked about one egg and getting an embryo from that one egg. We touched upon that. With age and with failing fertility, with Asians having poorer fertility, if you do end up getting less number of embryos, and we freeze them generally these days, it is always prudent to discuss with your doctor about embryo pooling, so that the embryologist can create more embryos, freeze them, so that you have more of a cohort to transfer. And we did talk about even one egg being enough to create a good embryo, but if you collect multiple of these, even when the fertility is failing, you would still be in the game of getting a child of your own. And thirdly, I want to highlight something very, very important that both Pratik and Seema touched on, which was, you know the sperm quality might look really bad, but if you have multiple ejaculations, generally the second or the third ejaculate does tend to give you slightly better sperm. And it is always prudent to get your patient to do that on the day of egg collection. That's the first bit. And if the sperm quality is really poor, then even having counseling them for tisa pisa well ahead of time, so that you fall back on that on the day, so that we don't have to resort to a donor too early. So those are my take home messages, and shorts for others too.
सो आप सब लोगों ने बहुत सारी बातें हमारे डॉक्टर के लिए की। अब मैं अपने हिंदी दर्शकों को, जब वो तब से सोच रहे हैं ब्लैक व्हाइट एंड क्या हम बातें कर रहे हैं, तो हम आपको बताना चाहते हैं कि हम बात कर रहे थे आपके इन विट्रो फर्टिलाइजेशन या टेस्ट ट्यूब बेबी के बारे में। और आज यहाँ पे जैसा मैंने आपको शुरू में बताया था कि हमारे एम्ब्रियो डॉक्टर, एम्ब्रियोलॉजिस्ट, हु इज एन एक्सीलेंट एम्ब्रियोलॉजिस्ट, एंड आप सबको पता चल गया होगा उनकी नॉलेज के बारे में, उस नॉलेज को कन्वे करने के बारे में उनसे हमारी बात हुई। उस बात का जो निष्कर्ष निकला वो ये था कि हमारी एज तो बढ़ रही है, एज एक्सपेक्टेंसी हमारी बढ़ रही है, लेकिन ओवरऑल दुनिया का फर्टिलिटी रेट डिक्लाइन हो रहा है। उस डिक्लाइनमेंट में हमारा अपना बहुत बड़ा योगदान है। हम अपनी धरती के साथ तो जो कर रहे हैं, ग्लोबल वार्मिंग को कितना ब्लेम करेंगे, किस किस चीज के लिए ब्लेम करेंगे, उसके अलावा जो हम अपनी बॉडी की बैंड बजा रहे हैं, खाने पीने रहने सोने सारी चीजों को, अपनी बायोलॉजिकल क्लॉक, अपनी हर तरह की क्लॉक को हमने बिल्कुल किनारे रख दिया है। हम अमेरिका के टाइम से सोते हैं, इंडिया के टाइम से जगते हैं, या उल्टा जो भी कह लीजिए। ये सारी चीजें हमारी फर्टिलिटी को अफेक्ट कर रही हैं। उसके साथ साथ हम सारे, हमारे सारे सपने, चाहे हम लड़की हों या लड़के हों, एक है, हम सबको टॉप पे पहुंचना है, जल्दी पहुंचना है, शॉर्टकट से पहुंचना है, और उसमें हम कॉम्प्रोमाइज कर रहे हैं क्वालिटी ऑफ लाइफ। हम रुक नहीं रहे, सांस नहीं ले रहे, अपना प्रायोरिटाइजेशन नहीं कर रहे, और उसकी वजह से हमें बहुत सारी प्रॉब्लम्स आ रही हैं। जब हम 20s में हैं तो हम लाइफ को एंजॉय करना चाहते हैं, उस एंजॉयमेंट में हमारी कोई बाउंड्री नहीं है, कोई लिमिटेशन नहीं है कि हमें कहाँ तक जाना है। ऑल ऑफ सडन 35 to 40 में हमें याद आता है कि हमें बच्चा चाहिए। उस वक्त तक का जो डैमेज है उसको भूल के आप क्विक फिक्स चाहते हैं, आप स्विगी और जोमेटो की तरह बेबी भी डिलीवर करना चाहते हैं। वो संभव नहीं है। आपको ये सारी चीजें शुरू से करनी पड़ेंगी, थोड़ा थोड़ा टाइम हर चीज के लिए निकालना पड़ेगा, एक बैलेंस बनाना पड़ेगा। हम एज अ डॉक्टर आपसे बिल्कुल उम्मीद नहीं करते कि आप लाइव बैठ के जिए, लेकिन जैसा प्रतीक कह रहे थे कि सुबह से शाम हम लैपटॉप पे लगे हैं, तो मैं जोड़ना चाहती थी कि हम काम के लिए भी लैपटॉप यूज करते हैं, इंजॉयमेंट एंड रिलैक्सेशन के लिए भी लैपटॉप यूज करते हैं। फिजिकल एक्टिविटी, बाहर निकलना, लोगों से मिलना, हमने सब कुछ छोड़ दिया है। इन सब का नतीजा है कि हमारी बॉडी में बहुत सारे एपिजेनेटिक चेंजेस हो रहे हैं। जेनेटिक्स तो आपके पूर्वजों ने आपको दी, लेकिन ये जो हम कर रहे हैं, इससे हम बहुत सारी चीजों को बदल रहे हैं, और उसका नतीजा है जो आप कह रहे हैं कि हमारे मम्मी दादी कहती हैं कि हमको 10 साल बाद बच्चा हो गया, आप लोग को इतनी हड़बड़ी क्या है? क्योंकि हमने अपने अंदर इस तरह के चेंजेस ला दिए हैं। तो इसको बदलने के लिए दोस्तों शुरुआत कहीं से तो करनी पड़ेगी, और मैं अपनी जनरेशन अल्फा एंड जी पे बहुत ज्यादा भरोसा करती हूँ, और मुझे लगता है कि ये जनरेशन इन सारी चीजों में चेंज करेगी। वो अपनी लाइफ में एक बैलेंस लाएगी, प्रायोरिटाइजेशन करेगी। आप खूब आगे बढ़िए, खूब एंजॉय करिए, लेकिन साथ ही साथ अपने हेल्थ का भी ध्यान रखिए, क्योंकि अल्टीमेटली, जैसा मैं हमेशा कहती हूँ, नेचर ने हमें इस चीज के साथ पैदा किया है कि हम चाहे प्राइम मिनिस्टर बन जाएं या झाड़ू पोछा वाले, बच्चा तो हमें चाहिए ही चाहिए। वो इनर happiness is engraved in us by nature to procreate and to keep procreating and growing as a civilization. So thank you, good night, शब खैर। मुझे लगता है आज के लिए इतना ही। प्रतीक ने आकर के आज पूरा माहौल ही बदल दिया। हमने बहुत सारे इंटरेस्टिंग Thank you, Bachcha. And it was really nice show. Thank you, viewers. And thank you, my lovely friends, Dr. Anuradha Khar, Raj Lakshmi Wala Walkar, and Dr. Arshik Bal.
Thank you, ma'am, for having me.
Dr. Arshi, you want to tell something about
Pratik,
us?
special thanks to you.
About?
You
Vote
made it.
appeal.
Oh, so my dear viewers, my friends, Italians, my request to all, please, please, please vote and support my dear Anuradha Khar for the post of managing committee. And the lines are open. And very, very important, don't forget my dear Seema Pandey, the loveliest lady on this show. Lines are open. Please vote her for the post of treasurer, librarian.
Librarian.
Please, please, we await. We are
Benedict.
really
हो चुका.
awaiting to have your response and cast your vote. Please don't lose it. Thank you so much.
Thank you, Dr. Pradeep. It was a wonderful
Thank you,
session. Thank
ma'am.
you so much. Thank you, everyone.
And Dr. Pratik, we would love to host you again in future for some other
Definitely.
insight and many of the fields you are working on. And we would like our youngsters to be aware about that too someday, somewhere. Thank you so much.
Thank you, ma'am. Thank you so much.
Bye.
And viewers, please take very good care of yourself. नॉर्थ इंडिया में ठंड इतनी पड़ रही है कि मैंने भी जैकेट और स्वेटर दोनों पहन रखा है। देखो, मैं कभी वुलेंस पहनती नहीं हूँ, तो बहुत ठंड से
और
बच के अच्छे से रहिए।
और सबको
ठीक है।
हमारी तरफ से मकर संक्रांति की
हैप्पी मकर
शुभकामनाएं। हैप्पी
संक्रांति,
Happy
संक्रांति, पोंगल,
पोंगल,
I
Bihu.
hope
जितने
you
नाम।
enjoyed your festival today.
Happy
And
festival.
thank you, Pratik, for this valuable
Thank you,
hour
ma'am.
you
Thank you.
gave me once again. Okay, Vicha. Take care.